Welcome back, everyone. Today, we're diving into the incredibly complex, but honestly, utterly fascinating world of interventional radiology. We're going to crack the code on selective versus non-selective catheterization, and we'll be breaking down some excellent insights from a recent AAPC Hyderabad local chapter presentation. Now, if you've ever stared at an IR operative report and felt like you were trying to read a roadmap in a totally foreign language, trust me, you are not alone. These procedures involve navigating a literal maze of vessels, and knowing exactly where a catheter starts and stops, well, that is the whole game when it comes to accurate coding. So grab your notes and let's unravel this together.
Here's our game plan for today. We're going to cover an intro to IR, how we classify these procedures, the difference between diagnostic and therapeutic, mapping out the vascular families, and finally, applying the core clinical coding rules. All right, let's jump right into Section 1, Introduction to Interventional Radiology. When we think of same-day surgery, we usually picture traditional operations, right? A sterile surgical environment, general anesthesia, and of course, large incisions. But interventional radiology completely flips the script. These procedures use real-time imaging guidance to perform minimally invasive percutaneous procedures using just tiny needles and really thin catheters. And here's the fun fact for you. Because IR relies on the body's natural pathways instead of making large incisions, patients often go home with literally nothing more than a Band-Aid. That means way less risk and a much, much faster recovery. Now, here's the crucial takeaway. While all interventional radiology procedures are technically a form of minimally invasive surgery, because, they use small portals and image guidance to access internal tissues, not all minimally invasive surgeries fall under the umbrella of IR. Interventional radiology is its own specific specialty that is entirely dependent on real-time imaging to drive those catheters to their precise targets. Moving right along to Section 2, Classification of IR. Look at how this visually divides the entire specialty into two massive branches. Over on one side, we have vascular IR. This is where the physician is working directly inside the blood vessels, basically the internal highways of the body, to restore or improve circulation. And on the other side, represented by a completely different network, is non-vascular IR. This branch focuses on treating organs or tissues that are completely outside the vascular system. Honestly, knowing which branch you are dealing with is step one in deciphering any IR operative report. Here's a really clear side-by-side breakdown of clinical examples for both classifications. Having this mental matrix is going to help you quickly categorize procedures as you review patient charts. Under the vascular column, you'll see things like an angiogram, which is visualizing the vessels, or an angioplasty and stent placement, where they're actively opening up a blocked vessel. It also includes procedures like thrombosis to break up clots or embolization to block off a bleeding vessel. Meanwhile, looking at the non-vascular side, we have procedures involving distinct organs. So think fine needle aspirations, needle biopsies, tube placements like a nephrostomy tube, or tumor ablations. Having these buckets in your head will instantly orient you when reading clinical documentation. Next up is Section 3, Diagnostic versus Therapeutic. Think of it like this. Diagnostic procedures basically act like a scout. The physician is guiding a catheter in and using contrast dye purely to visualize the area, focus on the imaging, and figure out exactly what the problem actually is. A classic example would be a diagnostic angiography to detect a blockage. Therapeutic procedures, on the other hand, are the fixers. They actively treat or manage the condition using those exact same image-guided pathways. So if your scout finds a blockage, the therapeutic procedure, like a balloon angioplasty or a stent placement, is what goes in to fix it. When you're coding, always ask yourself, are we just looking or are we actively fixing? Let's dive into Section 4, Vascular Families. The human body has three main structural families when it comes to these fluid highways, and in IR, we interact with all of them. First up is the arterial family, which handles blood supply management. It brings oxygen-rich blood away from the heart to the rest of the body, and the aorta is essentially the granddaddy of this family. Second, we have the venous family. These vessels manage the blood returning back to the heart. The inferior vena cava, or IVC, is a prime example here. And third, which is often a bit less discussed but equally important, is the lymphatic family. This acts as the body's drainage and security system, moving fluid and immune cells around.
Now, drilling down specifically into the arterial family, because let's face it, this is heavily tested and incredibly common in daily coding, we can map out these exact territories. It's basically a geographical map of the body. At the very top, we have the intracranial arteries, supplying the brain inside the skull. Moving down, the carotid arteries supply the neck and face. In the chest, the coronary arteries wrap around and supply the heart muscle itself. Lower down in the abdomen, the visceral arteries branch off the aorta to supply internal organs like your liver and spleen. And finally, the lower extremity arteries, like the iliac, femoral, and tibial arteries, carry blood all the way down to your feet.
Finally, we've arrived at Section 5, Clinical Coding Rules. Let's put this into practice with a real-world scenario to track a catheter's progression. Step 1, the physician achieves access and places the catheter in the right femoral artery, advancing it up into the abdominal aorta. Then, from that main highway, in Step 2, they advance it down the opposite side into the left common iliac artery. And finally, in Step 3, they selectively navigate it even further down into the left superficial femoral artery.
Now, here is the core coding rationale that solves this whole puzzle. The absolute golden rule of vascular coding states that when coding selective catheter placements within a single vascular family, you only code the final destination. Why? Because that final code inherently includes all the lesser first-order or second-order selections it took to get there. The journey from the right leg up to the aorta and down into the left superficial femoral artery represents a single continuous selective path. So you don't code every pit stop along the way, you just code the final parking spot. This hierarchical map of the vascular families is truly your ultimate key to accurate coding. So the only question left is, are you ready to use these rules to crack your own selective catheterization cases? Thank you for watching and keep learning with Decode Healthcare with Harshal.